The next person to speak is Dr. Kevin Shard, and he is from Tyler Radiology Association in Tyler, Texas. So he's local to all of us, and I think what's really great about having him here is that it talks about the technology and the great everything that we have in such a small community. And I think that the technology he's going to talk about speaks volumes to what Tyler, Texas has and can offer to his patients. So, Dr. Short.
Thank you. Good morning. I'm from just down the road from Tyler. It's kind of an interesting road to get here. I started doing what I did in practice about 20 years ago, and when I was in training, I was very interested in interventional procedures. It was very new, it's exciting, did a lot of peripheral vascular work. But as my life and my practice have evolved, so have my interests. I've had several encounters with family members with cancer in various and sundry ways. My aunt died of metastatic breast cancer. My grandfather I diagnosed with metastatic urothelial carcinoma, and he later died. My uncle died of metastatic melanoma. My aunt died of a very unusual primary brain tumor called anaplastic ependymoma, very unusual for her. So I have been touched in many ways. The Y90 that we're going to talk about today, it's interesting. There was a young lady that I grew up with. I still think of her as young anyway. It was the daughter that my mother always wished she had. Came in with what she thought was a gallbladder attack. Had a CAT scan done in the workup in the emergency room. And the next morning, I was the one that had to tell her that I had to do a biopsy to biopsy her tumor that we knew and was confirmed as a hepatocellular carcinoma. She was 42 at the time, had two beautiful young children, and 2 years later, she had passed. But in that time frame, she underwent some procedures that I knew that I could do if I had a little bit of extra training, and one of those was Y90. And so I took it to heart. It took me a while to get there with the regulatory constraints that are in place. But I thought it was very important to bring this technology to East Texas. Didn't have to be done in Dallas, didn't have to be done in Houston or Shreveport. It's something that could be provided locally. And if you chose to do so locally, then you'd have that option to stay a little bit closer to home. If not, at least not to have to hassle with the big city traffic. What Yttrium 90 is in Y90, there's several things I'm going to call it, so to keep it from being so confusing. It's easy to say Y90, and that's what our team refers to it as. There are other terms, it's selective internal radiation therapy. It's also called transarterial radioembolization, and it's a very unique way to get radiation to the tumor where the tumor does the heavy lifting, where the radiation does the heavy lifting of treating the tumor. You can see this nice schematic here. It's Y90 is embedded in microscopic resin beads, and it is embolized, in other words, injected into the arterial bloodstream to flow downstream to get to the tumors in the liver. It is designed wholly to treat the tumors in the liver. It doesn't do anything outside the liver. And so with that, it limits who might be a candidate for this. But those who are candidates for it, I think it's a viable option that might help them go a long way to control the tumor. Unfortunately, it's not a cure, but it is a very good palliation. In other words, it will keep you feeling better longer than doing nothing. And if you add it to chemotherapy, then most people do better for a longer period of time, have a higher quality of life, and can spend time doing what it is that they want to do than not adding Y90 to their therapy. The other thing that I might toss in here as we go along in the discussion are some of the other minimally invasive techniques, because sometimes you have to use them in combination. Sometimes one is better than another. As we've already heard, surgery is always the first option if possible. It is the best cure. If something can be cut out, it needs to be cut out. It needs to be put in the pan and be done with. Unfortunately, maybe a third of the patients that have metastatic disease to the liver are candidates for resection. We have to do something else to get them to candidates for resection. Radiofrequency ablation. It's putting a needle into a tumor and then running some energy through it. It basically treats the tumor with heat. It's very effective if you can get there. There's some anatomic limitations either by access routes or large veins and arteries that might cool that killing temperature where the tumor around these vessels does not get adequately treated. Hepatic artery chemoinfusion, it's been around for a while. Y90 is probably a better way to do it. Percutaneous ethanol ablation, nobody does it anymore. Cryoablation, instead of heating with treating with heat, you freeze it, and it has some adherence, and it has some options that, or gives you an option you might not have otherwise. Hepatic artery chemoembolization and selective internal radiation therapy, they're competing technologies. As I've mentioned, the way we go about treating this is embolizing to the artery that supplies the liver. The way we can get away with that is that the liver has a dual blood supply. The majority of the blood going to the liver that sustains the liver actually comes from the veins that drain out of the intestines. So when you eat something, things get digested, all those nutrients flow into the liver via the portal vein, and that's what sustains the majority of the liver. The other side is the arterial side, and that is it's important, it's necessary, but we know from other experiences that we can block off certain branches of the hepatic artery. The liver does fine because of the portal venous supply. The other thing that we do know is that the most tumors have their blood supply derived from the arterial side. So if we can limit the blood supply to the tumors by attenuating the arterial supply, the normal liver is going to do well because it has the portal vein supply. And so that's why you can have some embolization therapies, the Y90, the chemoembo, and a generic thing we just call the bland embolization, where we're basically choking off the blood supply to the tumors. Here's another, this is a couple of CT pictures. This really kind of shows you how the blood supplies are parallel. This is contrast in a CT that's injected via the artery. Via the portal vein, and it's supplying the normal liver parenchyma, these black things here, those are all the tumors, and that shows you that the normal liver is getting perfused, and then this is the tumor getting supplied via the arterial injection, and this is what we want to see. Nice schematic. The way we go about it is we get in the artery that basically crosses one of your hips, slide catheters up to the arteries that supply the liver, and this is a little cartoon showing the microcatheter going out into the branches of the hepatic artery and infusing these little beads. The idea is to get enough radiation to the tumors themselves to kill the tumor but not kill the liver, and that's one of the advantages of putting it in, the radiation in through the artery, is that you don't have to worry as much about the radiation getting to the normal liver. If you treat with the liver with radiation with external beam, it has to pass through the normal liver to get to the tumor. The tumor moves with every breath, and so as people lay there and breathe for the external beam radiation, it makes it harder to focus that beam, but it also, no matter what angle they take, even if they change the angles, the normal liver still gets a fair amount of radiation, and if you've got numerous tiny nodules, it makes it even harder for that technique to work. Whereas if we let it flow in through its own blood supply, then the level of radiation in the tumors gets very high. Think of it as dumb bees that kind of float along with the blood supply. They end up in the tumor. They're going to emit their radiation in the tumor, but because they're surrounding the tumor, the radiation is very high in the tumor but low in the normal liver. This is an electron microscope of what these resin beads look like. I just think it's kind of cool because you actually see them. And they float together singly, and they kind of clump up a little bit, and they end up getting trapped in the capillary bed. They are bigger than a red blood cell, but smaller than some of the other embolic agents that we use. And because of that, they basically collect like a sieve on the little capillaries that supply the tumor. And because they collect at that sieve, the radiation surrounds the tumor but doesn't necessarily pass through the tumor and into the normal, say, lung, anything downstream. Here's some other competing technologies. It's some drug-eluting beads. They're much bigger. Their impact, if you use some of these competing technologies, is that it has more of an embolic effect. In other words, it cuts down on the blood supply more than getting whatever chemotherapeutic agent is it's soaked into the tumor. Y90, because it doesn't block off the larger branches, allows it to percolate into and deeper into the tumor to let the radiation do the heavy lifting. And this is a picture, actually Dr. Kennedy, I think, is the one that provided it. And you can see this micrograph, and you can see these little black dots are the beads. Here's the tumor, and you can see it starting to collect on the periphery. And these little areas that he drew around show very nice that how intense the radiation can be around the beads and in the tumor. And this is what I think is very cool, because if this is enough to treat the tumor, and you've got some clusters that are centered in these tumors that are even significantly higher than what can kill the tumor, you know what kind of results you could potentially get with this technology. What can we use it for? Any tumor that's in the liver could potentially be treated with this. Again, if it can be operated on and cut out, that's the first choice, always the first choice if possible. But sometimes people, for medical reasons, they can't undergo anesthesia. Their heart can't take it. They're too old, and they just don't. Their ability to recuperate from something like that might not allow them to undergo surgery. So then you can have chemotherapy, which is great. Chemotherapy and radiation with Y90, that's a good combination. What we look for Y90 is it has to be predominantly metastatic disease to the liver. If somebody already has metastases to the brain or to the spinal cord, that's going to limit their ability to continue to function on their usual activities of daily living, they might not be the best candidate. We don't want to take somebody who is moribund and is really not going to tolerate anything and then try to treat them with this. We smack the liver around pretty good, even if the dose is calculated correctly. We want people to function and feel good. We don't want to make them sicker than they already are. If there's extensive extrahepatic disease, this might not be it. If you've got tumors that are just in the liver, this is something to consider. Why? We want to make sure that we do everything we can do to prolong the function of the liver, because if you've only got liver disease, and it continues to expand, you have to have a basic normal amount of liver to continue to function and feel good. And if we can control that, you will function longer and feel better. That's the way I look at it. It's a very simple way to look at it, but that is what it boils down to. Let's give the folks with this disease something to make that gives them a higher quality life, longer lifespan, so they can do what they want to with their family. We do have to have adequate liver function, and so that will sometimes limit those who can receive this treatment. And the gentleman that was up here, Mr. Salgado, he is a great example. His liver he always had good liver function until he received his transplant. If you don't have good liver functions, it can be hard on the liver. So there are certain parameters that we have to look at. If you meet those parameters, then more than likely you're going to be a candidate. There had been some size criteria. I don't abide by that as long as we've got an adequate amount of normal underlying liver to work with. That to me is what's important. But you have to have bilirubin that shows that it's low enough that there's enough normal functioning liver there to tolerate it. Another one is albumin. Albumin is just a protein that floats around in your blood, and it shows if you've got a high enough level that your liver is functioning adequately to be able to tolerate this treatment. There is some of the other chemotherapeutic agents that people are on, particularly if you have colorectal carcinoma with metastases. One is Xeloda. We can work around that. Avastin is something that we'd like to hold, and it's interesting because it's what it does is it slows down the angiogenesis of the tumors. In other words, the tumor blood supply. The tumors try to create their own blood supply, and Avastin slows that down, but it also inhibits the ability to get our beads there, but it also makes the arteries that we're working very friable and makes it more prone to damaging the arteries just on the arteriograms that we've got to do. If you've had other radiation, sometimes I might limit it. It really just depends on the dose of radiation that you've gotten. Ascites is just one of those things, and bilirubin of greater than 2. It just is an indicator that maybe your liver is not healthy enough. The normal leftover liver is not healthy enough to tolerate the treatment. And then there's some other reasons that we might not be able to do it. If we inject the Y90s, then the beads do not get collected at the tumor. They pass through the liver, and the first thing that they see is the lungs. And we don't want too much radiation in the lungs because it can hurt the lungs. And so that's what this liver to lung shunt is. If it's less than 20, and which is most of the time, you can get treated with this. If not, then we have to get fancy and try to see if there's a way that we can orchestrate it where a patient could potentially receive it. And the other thing is the abnormal hepatic vasculature. We'll get to that in a second. Early on, portal vein thrombosis or partial thrombosis was something they didn't think the patients could tolerate because we're counting on the portal vein to maintain the normal liver, and as we attenuate or block off the hepatic artery, it's been shown now, even with portal vein thrombosis, people can tolerate Y90, which has actually expanded the number of people who can receive this treatment. Who can get it? I have treated probably a dozen different tumor types now in just the several years that I've been doing it. Hepatocellular carcinoma is one of the acknowledged tumor types that can be treated with this. Metastatic colorectal carcinoma is one of the recognized tumor types that can be treated with this. But pancreatic metastases, breast metastases to the liver, lung cancer metastases, anything that we think the tumor type is going to be radiosensitive, we can treat with Y90. What we do is it's not a one-off procedure. It's a series of procedures that have to be done in the correct sequence to get things accomplished. As mentioned, we have to get into the artery and inject the Y90, let it float downstream. But what we do not want it to do is to get into the branches that are not going to the liver because they're dumb beads, and wherever they land, they're going to emit their radiation. And if they land in the pancreas, it can cause pancreatitis. If it lands in the stomach or the intestines, it can cause ulceration. And if it gets through the liver and into the lungs, it can cause problems. So we want to know where they're going to go. We've got a plan for this. And so we take a bunch of pictures beforehand, and we look for branches off. This is the branch that goes to the liver, and this is a branch that goes to the duodenum and part of the stomach, and here's a branch that goes to the stomach, and we don't want those anymore. So we purposely will go in and we'll block off. This one's called the GDA. This one's the right gastric. And if there are any anomalous branches that we don't, in other words, branches that aren't usually there but can be, we block them off purposefully with little metal coils. And what that does is it skeletonizes, like pruning down the tree, so when you water it, the nutrients only go where you want it. Well, we only want the radiation to go only where we want it. And so we block these things off. Here's an example. Here's the right gastric. There's a little microcatheter in here, and I say micros because they're like 1.5 millimeters. They're pretty small, but they can go to places that before you just couldn't get to. And you inject little metal coils that look like this on the images that block them off. So that big GDA that came down here has been blocked off. This little gastric artery is going to get blocked off. And so you end up with something like this. This is kind of a magnified view of the picture that was up here. But this blood supply, this black stuff, is the contrast that flows downstream, so it only goes to the liver. So when we inject the Y90, it's only going to flow down here. It's not going to go down here to get the intestines. It's not going to go over there to get to the stomach. And then we check one more thing. So this is a multiple test to get there to make sure that we've gotten everything perfect before it's time to treat. The last thing we do on what we call the mapping arteriogram is inject a little bit of diagnostic non-therapeutic radiation, and what that does, it checks our work. It's the easiest way to find out if we missed a branch that we couldn't see. And also, this is how we calculate how much activity radiation might get to the lung to keep the lung exposure to a minimum. And we inject what we call MAA. It's just it's this radiopharmaceutical we use for a lot of different stuff, and we take a picture. And this is what you want to see. Here's the liver. This is the outline of the liver. If you've some of the other pictures you can see, this is just a picture of the liver. These hot spots could be tumors, and it's a nice thing to see because you know that if you're accumulating MAA in the tumor, that those tumors are going to get a very good exposure to the radiation when it comes. What you don't want to see is this little tail out here where a side branch was missed. And what that means is that the activity is getting into the stomach or the pancreas, and we have to go back and look and try to block those things off to make sure it's safe to deliver. And then we use this as how we calculate how much goes to the lung. And these are some of the things that you might see. These little spots right here are tumors. And it doesn't necessarily mean if you see tumors like that they're going to get treated better than if you can't necessarily see them on arteriogram, because arteriograms are not the greatest way to diagnose tumor. CTs, MRIs are the way to do it. But if you see that, it's just satisfying because you know you're going to get some activity to those tumors. And this is a gentleman that had multicentric hepatocellular carcinoma. And the interesting thing is we knew about this tumor on CT and MRI. We didn't know about all these little tumors. And his tumor type and his particular, on this particular arteriogram, we could actually see the tumor burden was a bit more extensive. So sometimes it goes both ways. But if you see this, you know it's going to get radiation when we administer it. This is just another example. Here's what it looks like beforehand. We don't want this branch. We don't want that branch. So we block them off, get them down so the Y90 goes only to the liver. Here's another example of a couple of different neuroendocrine tumors, just trying to give you an idea of the variability of the tumor types that can be treated with this. A lot of these carcinoids, peanuts, neuroendocrine, they generally fall into the same category tumors, but oftentimes you can see that they can be hypervascular. In other words, they just show up really well in arteriogram. You can see this kind of a claw on this tumor down here. It just goes to show that you're going to get some a very high deposition of activity in that tumor. This is one that hepatocellular carcinoma. It's infiltrating where the right and left lobes of the liver come together. The left portal vein is partially involved. You can see a part of it right there. This is one, because of its location, it's very difficult, it's impossible for them to operate because they basically have to cut the center out of the liver. This, because of distribution, and then in the next slice up, you would see hepatic veins coming out here. It's not a great place to do radiofrequency ablation either, because you can't cover all the tumor and get all the tumor that's in the nooks and crannies around all these critical vessels. Y90 can get there. Okay, if you're a patient, well, what are the side effects that you're going to have? What is it that you can look forward to? A lot of the patients that I do treat have already undergone at least one regimen or are beginning a regimen of chemotherapy. Y90 compared to some of the other embolic therapies is very well tolerated. If you do a transarterial chemoembolization, which is kind of a competing technology, or a drug-eluting bead embolization, because, as I mentioned earlier, those particles tend to work on a larger branch vessel. The degree of nausea, abdominal pain, fevers, and chills is just worse than Y90. Y90, the biggest complaint is some nausea, but it's lethargy. What I typically tell my patients that beginning about day 4 or 5 after the Y90 treatment day is that they're going to start to get fatigued. And depending on the individual, it might last a few days, it might last a week, sometimes 2 weeks, where their ability to just want to get up and do things is, their get up and gone has kind of gone away. A lot of times they still want to do, they can still get up and do a lot of things. Some people try to make it to work, some people don't. I had one guy that I just loved it. He was great. I treated him twice, and every time he goes, "No, doc, I just go fishing." And that's what he did. He goes, "Oh, I know I'm going to be off for a couple of days." He goes, "So I just go fishing." Some people, it is more debilitating. But they can still get up and move. They can still get up and they can shower, they can bathe, they can cook and do a little bit of cleaning if they want to. But it does not put them in bed where they don't want to do anything for weeks at a time. They don't get that sick. There could be some pain. It's usually treated with just some oral pain meds. Nausea is not infrequent, but that can be treated with some pills as well. So everything that we do is geared to be done as an outpatient. So you come in, do your mapping, bring it back a week later, you do your first treatment. bring you back in about 4, 5, 6 weeks after that to see how you're doing it. But we don't intend for people, the patients, to receive this to be in the hospital. We want them at home. We want them to be with their families, and the tolerance is such that they can be. So this is what I just kind of ran down a little bit. This is the kind of the treatment thing. This is what we do. We see them, we evaluate them. We do the mapping arteriogram. We do that picture to see if it shunts to the lungs. We check their labs and make sure that nothing has changed. Then we order the dose and bring them back. And it just takes a week to procure the dose, at least in Tyler. And some of the larger centers, they probably have some stock. We're not that busy. We order the dose for each patient. They make it. They fly it down early the morning or the day before the dose, and we treat it. Bring you guys back in a month or so, see how you're doing, and if all things look good, then we're going to treat the other part of the liver. What I didn't mention is I treat one lobe of the liver, then the other. There's a right and left lobe of the liver. I tend to treat the one that's, if the disease is somewhat symmetric in the right and left lobes, I treat the lobe that has the most technically demanding treatment first. Only why? It's because let's get the hard part out of the way. And then the next time it's going to be easier, so the procedure times get shorter and shorter and shorter as the patients go through this multi-step procedure. This is some tumors. You can see there's some tumors scattered around. This is what we really like to see, is when you've got these tumors and they disappear. I have not been that lucky in most of my experience. This is one of my patients. And you can see this is before the treatment, and there was kind of the pseudo capsule of a tumor, very kind of ill-defined. Then a month after treatment, that capsule is broken down, and then the tumor itself actually gets this kind of funny we call it ground glass density change. The tumor doesn't really measurably shrink in that short of a time, but I know that it's received the radiation, and it will start to shrink. And this is a similar case. Here's the tumor beforehand. This is one of my cases, and this is 6 weeks later. We can already see some shrinkage. That's always nice. A little bit more scientific. What this means is Surflock's study was a study that was completed and published a little over a year ago. And what it shows, people that have liver predominant, have colorectal metastases to the liver, if they get Y90 in addition to their chemotherapy. If they've got disease only in their liver, the Y90 and the chemotherapy combo does extremely well in prolonging higher quality of life for a longer period of time. If you've got substantial disease outside the liver, it is not much more effective than chemotherapy alone. So if you're a patient with liver tumors that has received chemotherapy, is going to receive chemotherapy, adding Y90 to it is going to give you a better shot at a higher, longer quality of life, higher productivity. Yeah, this is just showing that you always get, in general, what I tell my patients is you get at least a 25 to 30% prolongation of the life if you receive this treatment in higher quality of life. It doesn't make you sick as some of the other chemotherapy regimens do. And this is a similar thing for hepatocellular carcinoma, because those are the two largest groups that have been studied with large enough numbers to get statistics, is that if you take somebody with hepatocellular carcinoma and you treat them with chemoembolization or radioembolization, you're going to get about a third 30% or a third longer of higher quality of life than not adding this treatment to whatever it is that you're getting treated with. If it's a pill chemo, great, we can add this to it. If it's a more aggressive chemotherapy, great, we can still add it to it if your liver can tolerate it. This is just kind of how there's a delivery box if you guys want to see it. It's kind of neat how they set it up. This is the catheters already in the patient here, and we attach the actual beads with the radiation in here, and you push them through with some catheters, through some sterile lines and into the body. And this is interesting. This slide sums up in this line. This is what I tell everybody. It's the 3 feet for 3 day rule. It's your radiation. Keep it stingy. Don't share it with others. If you have a large bed, that's great, but 3 feet for 3 days, and that's just to keep the exposure to others as low as possible. if you're going to, one of my patients was concerned because I had a lap dog. Well, followed up with the patient a year later, and the lap dog never lost any hair, so I think we're pretty safe. Most of the radiation, it only travels about 2 millimeters, which is just that much from where the bead lands, and most of the radiation doesn't go more than about 1/3 of an inch. And so most of it gets attenuated by the body wall, if not the clothes that you're wearing. So yes, it's safe. You're not going to set off any radiation warnings. But I have written letters for patients who were traveling either to the border or that had planned on flying, so they had a letter. So if they did set off a TSA alert, that they've got some documentation as to why they are. Some of the side effects or complications, I've already kind of mentioned it. Here's a little bit of activity outside the liver. That's what we don't want to see. And a lot of times it doesn't take much to get the ulcer disease developed, and we just have to work through that. Luckily, I've not had one yet, knock on wood. I've had one patient with an ulcer. It was a bland ulcer. In other words, they just developed ulcer disease, and that wasn't related to the radiation. And this is something that the radiation-induced liver disease, you always have to take a little bit of the bad with the good. And even though the liver functions by the numbers look good, by the patient's ability to get up and function, do what they need to, in other words, their ECOG status is great, you can still have people that their liver just doesn't take it. And that's a problem. I've not seen it yet, but it's something that I talk to everybody about. Thank you.
Thank you, Dr. Short.